Yeah. Are you guys able to see this?
Yes, looks great.
Excellent. So as I mentioned to Andrew and David, I'm on a laptop. So if you want to ask a question while I'm talking, please just speak up, because I'm not going to be able to see the chat, but I'm happy to be interrupted at any time and to answer questions. So thank you so much for the invitation to be here. I'm really excited to be telling you a little bit about some of my recent thinking about the design choices that we make when we develop interventions and implementation strategies, and why those design choices actually matter, and how to think about that in a principled way. And so I started thinking about this actually a long time ago, and I'll come to that in a second, but sort of the overall point that I'll try to make in this seminar is that different specific designs, operationalizations of an intervention or implementation strategy, can have differential effects on the causal pathway through which that strategy or intervention is intended to operate, and that those differential effects is particular on moderators and preconditions of the operation of the intervention or the strategy can result in different effectiveness. And that using tools like simple causal pathway diagrams can help you sort of think through that, both in advance as well as make sense of the results that you have from your previous studies. And so I'll try to flesh that out as we go forward today. And so I started thinking about this actually almost at this point 15 years ago, when I was still a PhD student at University of Washington, and my second year of the PhD program, I got an internship at Intel Research Seattle, and I was working with Sunny Consalvo, who was a researcher at Intel at the time. She's now at Google, who was developing this system called UbiFit, which was a physical activity intervention that was one of the early sort of smartphone-based physical activity intervention. It had a mobile app on the phone running on Windows Mobile, and then we had this sensor called MSP that Tanzim Chaudhry developed that basically was one of the early sensors that could automatically detect a range of activities. So things like running and walking and being on a Stairmaster, biking and things of that sort. And so one of the things that was interesting about UbiFit is that Sunny developed this live wallpaper for the phone that you see on the left here that had these pictures of flowers that was supposed to provide basically ambient feedback on your physical activity. So you would get a flower for every activity you did. So if pink was, I think, walking, blue was strength training, and so on. And so basically it was sort of a visual representation of the journal that was contained in the app on the phone. And so it was basically representing the exact same data you could get to by going into the phone app, but in a visual form and on the background screen of the phone, right? And so part of this project was basically to run a study that compared how people did when they had the garden display versus if they only had the app on the phone without the garden display. And in both cases, we gave people these sensors to wear to detect activity. And what was interesting is that one of the things that they found is that people who had a garden display ended up staying sort of steadily active over 12 weeks, while people who did not have the display but had all of the other components, their activity decayed, right? It declined. And the garden display group actually managed to maintain their activity even through the holiday seasons, like November and December, which is pretty nasty in Seattle, but also people tend to sort of fall off the wagon in terms of physical activity. And the question is, why was this difference in effect, right? So one of the things that is interesting here is that if we look at this system in terms of behavior change techniques, basically both variations of the system had exactly the same things, right? So it had feedback on behavior and goal progress. There was self-monitoring of behavior. There was goal setting. And you really couldn't do anything different with the garden version of the phone, of the app than a version that did not have the garden. So what was different is that the feedback was seen more often if you had it on the background screen of the phone, and that people didn't have to remember to go into the app. And really, sort of when we were thinking about how to make sense of these results, one of the things that really sort of stood out is that the garden display made the feedback more salient more frequently, right? So every time people would pull out the phone to check their calendar or make a phone call, they would see feedback about their physical activity. And in fact, sort of the qualitative data from participants pretty much told the same story. So here's one example where it says, every time I see my phone, it's a friendly reminder that I should be doing something. That was great. That was really cool. So it's basically this notion that people could just see the feedback without having to go into the app, right? And so starting with this, basically this was the first real data point for me that really solidified this notion that how we design, even the UI of these digital interventions can make a difference, right? And then when I came to Michigan a few years later, I started teaching this class on prototyping and evaluation of consumer health technologies. And the way that this class is structured is that we basically go through a whole bunch of behavioral theories. People read, the students read primary materials about this, and then we sort of discuss about how does this apply to how you would actually design these behavior change techniques if you were designing real systems. So, as an example, they might read the American Psychologist article from Locke and Latham on goal setting, and learn about, basically the data about what aspects of goal setting matter, right? That goals improve performance, specific goals are better than vague goals, and so on. This is all of the stuff that you guys already know. But one of the things that's really interesting is that even if you actually take all of this data in, there are a whole lot of new questions that pop up when you're trying to actually make a concrete goal setting interface. So here's just some of them, right? One is sort of the timing, when and where within the system to set the goal. So both in terms of when to prompt the people and how to put that within the system. How many goals to set, right? For how many behaviors? Should there be a backup goal, like we had in UBFIT, for example? Who sets the goal? Should the user set the goal? Should the system set the goal? Should there be some kind of negotiation? What is the time frame for the goal? Is it a daily goal? Is it a weekly goal? One-time goal? Whether there is a hierarchy of goals and so on, right? So there's a whole bunch of questions that have to be answered if you're going to design a very specific instantiation of a goal setting interface, or for that matter, any other behavior change technique that you might want to implement, right? And the big question here is which of these questions actually matter, right? So if we think of it to try to think of it in principal terms, some of these questions probably are more around just overall usability of the system, while others might actually impact the performance of the behavior change technique. And it's not clear that we currently have a principled way of thinking about which is which. So that is sort of the big question that I've been struggling with for a number of years, is how to think about design choices during the development of digital interventions in a principled way, and given the large number of potential forms that any given intervention component can take, right? And as I was sort of playing with these ideas during the class, I started doing some work in implementation science with a bunch of people from Kaiser and UW, many of whom you know, trying to sort of think about how to improve the methods in implementation science to make implementation initiatives more effective. And in very broad terms, the problems that we were trying to deal with is the fact that many implementation efforts fail. Nearly half of them don't have outcomes, and that there's sort of high cost and complexity of creating implementation initiatives, and often they also contribute to inequalities, right? And part of the issue here is that we were just sort of trying to focus on a number of more specific problems that might lead to these large issues in the field. And just to make things concrete, let's say you were trying to implement regular depression screening in primary care, right? The idea might be that if you have regular depression screening in primary care, you might that can lead to higher rates of referrals, which will then have better mental health outcomes. The question, though, of course, is how to get to this regular depression screening point, right? And what kind of strategies to deploy to get there, right? And there are a number of issues of trying to answer that question. One is that we have a whole bunch of different strategies, right? So there are over 100 of the discrete strategies, and many new ones are being created as we speak, right? And it's difficult to choose from the many strategies that exist which one need to be used to actually get to the implementation outcomes we care about. Sometimes we choose strategies and they're misaligned with the barriers that we have in a setting, right? So if the main barrier for regular depression screening is, let's say, divided attention, something like audit and feedback is probably not going to help very much with that, right? So often we end up with initiatives that try strategies that don't actually particularly well align with the barriers, right? Other times you might even you pick a strategy, and you might actually get to some of the initial outcomes like the high rates of screening, but that might not translate to the downstream outcomes like high rates of referral that are needed to get to the clinical outcomes we care about, right? And so as we were sort of thinking through these things, one of the things that occurred to us is that we might actually do a better job of designing implementation initiatives in a more principled way if we try to really be very explicit about what might be going on for any given implementation strategy that we might deploy, right? So to how does that strategy work? And so we started to develop using these graphical accounts that we're calling causal pathway diagrams to try to make explicit our sort of the hypothesized causal process through which we think the different implementation strategies function. And the idea here is that these causal pathway diagrams can aim to support more informed planning and evaluation of implementation initiatives by making explicit how strategies are thought to bring about change, right? So you can sort of think of this as a theory of change at a micro scale for each individual strategy, right? And the sort of simple way to think about these CPDs is that they're adaptations of directed acyclic graphs, right? But there are the adaptations that make explicit the role that each node plays in the process. And you can use them then to both support decision making about sort of what strategies to choose or how to operationalize them, as well as to make sense of initiatives that are already going on. So the kinds of questions that you might be able to answer using these diagrams is it plausible that the strategy can resolve a targeted barrier? Well, what must be in place for the strategy to have a chance of working? What factors make the strategy work better or interfere with its operation, and so on? And so to just give very quickly, so to give you a sense of how these things work, most of these diagrams that we've been using have roughly this kind of a form, where you have basically this stem along the middle of the diagram that is supposed to provide to describe the actual core of the causal process through which that strategy works. So in this particular case, if you have a clinical reminder, the mechanism through which that strategy might work is to enhance the salience of the need to provide a evidence-based practice. That might address the barrier of divided attention, right? And then you have a set of outcomes downstream from that. So from near-term outcomes like the clinician forming an intention to provide a screener, to sort of higher rates of depression screening down the road, and then finally all the way to clinical outcomes that might, in this particular case, involve improved depression outcomes. What is important about these diagrams, though, is that they also have these leaves that we're sort of referring to as effect modifiers that basically try to describe what are the moderators and preconditions that need to be in place for the strategy to work effectively, right? So for preconditions, we think of preconditions more like sort of light switches, the things that if they're not there, the part of the causal process to the right of that precondition is just going to break completely, right? And so, if in this particular case, even if a clinician decides to screen, and they're using, let's say, paper screeners, if the screeners are not available in the exam room, the rate of depression screening is not going to improve, right? Well, moderators are the kinds of things that we normally think of as moderators that sort of increase or decrease the effectiveness of that part of the causal process. And so things like habituation, for example, to prompts might be a moderator that will modify whether the mechanism gets activated. While further down the line, you might have something like a clinic visit length as a moderator of whether the clinician actually screens, even if they actually perceive the reminder and are they think that this is actually an important thing to do. So with these kinds of diagrams, you can answer a number of questions, right? So the part of the stem of the diagram can help us clarify how strategy works to help align strategies to barriers, right? So you can actually try to say, okay, can I actually make a plausible case that this particular strategy is going to affect this barrier? And so we've been thinking of this notion of mechanism as a key construct through which to make sort of that claim, right? Is that if you cannot come up with a plausible mechanism through which a strategy would address a barrier, that strategy might actually be not a good match for that particular barrier, right? Making preconditions explicit allows you to put things in place to ensure that those preconditions are present in a setting, right? So that you might actually create things like a restocking procedure that might ensure that the forms are present in the room for clinicians to use, right? Well, moderators allow you to both address them through potentially different kinds of implementation strategy, as well as to sort of give you a sense of what needs to be measured to understand how well your implementation initiative is working. And then finally, sort of one of the key things that we think is really important about these causal pathway diagrams is that they help you really articulate what the early outcomes are of the initiative, so you can make course correction early, right? So instead of having to wait all the way to the implementation outcome. You can try to get at some of the more proximal outcomes and to see whether the strategies that you're deploying are working as intended. So the question is, okay, so we use these things to plan implementation strategies. How does this actually help us with intervention or strategy design, right? And for this, I want to actually give you a couple of examples. So the core idea here is that I think specifics of how the intervention or strategies is designed, including things like the user interface, graphical user interface for digital interventions, can influence important aspects of the causal process through which it operates. And I think the sort of how different variations of an intervention or strategy differentially influence the part of that causal process is my current thinking about why certain operationalizations of an intervention work better than others. So let's look to a couple of examples of what this might look like, right? So this is data from sort of the first micro-randomized trial I ever did, which was called the Hard Steps, which basically try to help sedentary adults increase physical activity through walking. And people had a sensor, wearable sensor, as well as a mobile health application on their phones that provided some push notifications, as well as there was an app with feedback inside that they could access it well. And there were two basic intervention components that this intervention had. One were these actionable context-aware activity suggestions, which aim to help encourage short bouts of activity throughout the day. And the other one was planning on when, where, and how the one would be active on the next day. So you can think of this as sort of a version of implementation intentions as a behavior change technique. And these activity suggestions really were intended to support short bouts of activity, right? And they showed up as little push notifications on the phone. And we had two basic variations of this that were really just variations in content, in just the text that the suggestion had. One of them was encouraging people to take a short walk, while the other one was sort of asking people to just move around a little bit, right? So it was much more of just disrupting sedentary behavior to get at least a few steps. And in both cases, the actual suggestions that were sent to people were tailored based on sort of real-time data about the time of the day, whether it was weekday versus weekend, the location that the person was currently at, so it was whether they were at home, at work, or some other places, whereas the current weather. Planning, on the other hand, also had two variations that were very much focused on trying to sort of differentiate how much burden is involved in planning. And so we had basically just a text box, which is, you can think of it as a digital version of how implementation intentional research is done in lab studies, where people just write down a plan on a piece of paper. And then the other variation was basically a list of plans that people had previously made. So some of the time, like given that our lives are routinized, people could just sort of make a plan that would likely be relevant for another day, and they could just pick it from a list instead of having to write it from scratch. And so the way that the study worked is that we had 42 adults over 6 weeks. And both activity suggestions and planning prompts were micro-randomized. So for activity suggestions, this was done 5 times a day, and where at 40% of the time the person would not receive any kind of a suggestion, and then 30% of the time each, they would get either a walking suggestion or an anti-sedentary suggestion. And the proximal outcome that we were looking at here, so the outcome of each of those randomizations was the number of steps in the 30 minutes following that randomization. So very much a near-term outcome, right? While for planning, the planning was micro-randomized every night in the evening for the following day, and basically half of the evenings people would not be asked to plan, and then the other half of the time they would be split equally between being asked to create a new plan from scratch, right? To write the plan in the text box, or choose a plan from a list that they had previously made. And in this particular case, our outcome for the randomization was the step count on the following day. So basically looking at does the next day's overall activity increases. And so I'll start with planning, because I think this is going to be a slightly easier thing to explain. So the main effects were not all that interesting, right? So there was no effect of if we average across everything. So basically both kinds of planning and as well as the whole study, there was not much difference between asking people to plan versus not. However, if we break down by the type of planning, it looked like open-ended planning added about 500 steps on the following day, while versus no planning, while choosing from a list didn't do anything at all. So we're starting to see some differences based on what UI was being used for planning. Where things get a little bit more interesting is when we actually start doing contextual analysis. And so what we saw was that basically for whichever reason, our participants did not like planning on weekends. So on weekdays, any planning versus not planning did help, right? So it ended about 600 steps a day, but on weekends there was no effect. But most importantly, the effect also interacted with the type of planning. So open-ended planning almost ended close to 1,000 steps on versus no planning on weekdays, while choosing from a list didn't do anything at all. And what is interesting for at least from my perspective for mobile health study, there was no decay in the effectiveness of planning. So insofar as we had an effect, it stayed constant over a course of time, right? And so the things that to take away from this is that really only open-ended planning actually did something, right? There was no effect for choosing from the list, and that effect stayed stable over 6 weeks. And so the question here was that it really comes down to why did this sort of difference in interface matter? And when I first sort of saw this data, I was sort of talking to Bonnie Spring, who might be on the call, and she very much nailed what is going on here, and I'll be coming back to that second of what we think is happening. But let's just start with saying, okay, so how does planning actually work? And so this is a simple causal process that derives from Peter Goldwitzer's and Pascal Sheeran's 2006 paper, which basically says that with these kinds of implementation intentions, that the sort of the main mechanism that happens that is being activated is that there's this encoding of both the action that needs to be taken as well as the context in which that action needs to be taken. And then that encoding neural encoding creates increased sensitivity to, right, or sort of salience for contextual cues related to that context. And once that context is encountered, basically the action initiation happens automatically without the need for further deliberation. So you would sort of create automatic action initiation would roll off, and you would actually do the planned action. There are some modifiers of this, right? So this happens, in case you don't have strongly held goals that are conflicting with the action initiation, as well as, of course, that if this is not going to happen unless you actually encounter the context in which for which that action is planned, right? So we have some of the moderators and the preconditions for this. But the key thing here is that potentially there is actually another precondition for this mechanism to be activated at all. And this was Bonnie's brilliant insight early on, that really you need a certain level of attention, that unless the planning intervention itself is done with attention, that encoding might never happen. And in fact, when we think about our two versions of the UI for this planning intervention, the UI actually basically guaranteed that for an open-ended plan, people had to pay some attention. While when they were picking from the list, that was done very quickly, and we have that in that sort of time-long data, that was basically people were just sort of getting through that screen in a second and a half, versus substantially longer when they had to write a plan. And it's possible that when they were just picking from the list, not the sufficient attention was not paid to the process of planning that was needed to actually encode the plan in the brain, right? So basically, this difference in the actual how the planning intervention itself looks was responsible for the differential activation of attention. And you can think about other moderators, for example, how important the activity is, that could be similarly activated through different design choices. For example, timing of a planning prompt. If you're sending someone a planning prompt while they're working on a grand deadline or something like that, and that you're asking them to plan physical activity, probably the value of perceived value of physical activity at that moment is not high, and that prompt is not going to work very well. So we're seeing here one example within digital interventions of how UI design can actually make a difference in terms of what part of the causal process it influences. We saw something similar, although substantially more complicated, with activity suggestions as well. So this is sort of the initial set of analysis we did, basically similar kind of things where there's not at the level of main effects, there's not much going on here, right? We only see an effect if we do a time trend over the course of the study, where we initially get up to about an extra 167 steps at the start of the study, but that particular effect sort of decays over time and is completely gone at the end of the month. What was important about this particular finding is that here too, we actually had a difference between the two types of suggestions. So for walk-in suggestions, you actually got 60 extra steps, both averaging across the whole study, as well as 270 extra steps at the start of the study, but then the effect diminished over time. But we saw no effect in these main effect analyses for the anti-sedentary suggestions. So anti-sedentary suggestions, when we first started looking at this, didn't look like they were doing anything at all. And so we started thinking about this and said, well, time in study is a weird construct. Like it's not really a particularly compelling psychological mechanism. And so one of the things that we were thinking about, especially given that people were telling us that they were starting getting tired of the suggestions that we were sending them, is are we just seeing habituation? Is this really just a one version of that basically the time variable is just being a proxy for habituation? So to look at that question, we started running some additional models, and I'll throw some regression tables on the next few slides. But for all of them, I have sort of the summary of what they're actually showing at the bottom of the screen, so you don't need to worry about trying to plow through the regression tables. But I think it's actually really interesting what we ended up seeing here. So the first thing we did is basically saying, if really habituation is what's going on, in that case, we should see an effect of the dose of the previous suggestions received on the effectiveness of the current suggestion. So we did a number of sensitivity analyses, including sensitivity analysis, where we looked at different time windows of how many suggestions people got over the previous 3 days and 5 days and 7 days, and seeing how that moderates the effect of the current suggestion. And in fact, what we start seeing is that if we look at the whole set of messages, so not distinguishing between walk-in suggestions and anti-sedentary suggestions, the previous dose seems to matter, right? The bigger the dose over the last few days, the smaller the effect of the current suggestion. Here's the data from the previous 5 days, I think, yeah. But we saw exactly the same kind of thing for 3 days and 7 days as well. So all of the numbers pretty much were identical across different kinds of time windows that we were looking at. So, okay, so we're starting to get some interesting data here that seems to suggest that maybe actually it is habituation that we're seeing here. But then, of course, if it is habituation, then this sort of funny time effect should go away, right? So the next thing we did is we basically created a model that both had the moderation by time and by dose. And what's weird here is that when we do that model, the moderation by dose goes away, but we keep the moderation by time in study. And so it's like, okay, so it's not something is weird here. So we started sort of digging into this and breaking this down further. So the next model we did was we basically tried to break down by suggestion type and looking at the moderation by dose, right? And what we find here is that when we break down with walk-in suggestions and anti-sedentary suggestions, and we look at the moderation by dose, both of these types of suggestions end up having a main effect, but only the anti-sedentary suggestions are moderated by the recent dose. So we do basically the coefficient for moderation by dose for walk-in suggestions is not there. So that gets even weirder. And so then we said, okay, so what happens if we actually we now combine both the walk-in suggestions, we break down both by walk-in suggestions and anti-sedentary suggestions, but look at both by dose in study, day in study, and by previous dose. And what we find here is that the two types of suggestions respond differently. So walk-in suggestions decay with the day in study, while anti-sedentary suggestions decay with the dose in the previous few days. They're sent in exactly the same way. They had exactly the same decision rules and probabilities. Visually, they're identical, right? So you actually have to look at the notification to be able to tell whether it's asking you to take a walk or just move around a little bit. But how these two types of suggestions respond is quite different, right? So the anti-sedentary suggestions seem to be subject to recent dose, while walk-in suggestions only decreased over time, but they're not. But from what we're seeing with planning, this is not actually due to study disengagement because the planning remains effective over the course of the study. So the question is here: why are the differences in patterns of responding, right? originally, when I first started sort of looking at this data, I was thinking, well, there must be a different mechanism that is going on here, that maybe the anti-sedentary messages really are just responding to habituation, and something else is going on for walk-in suggestions. But this doesn't quite make sense, right? First of all, it's not a particularly elegant, account, but also habituation as a construct is very much tied to the notion of just a stimulus, right? So someone getting pinged by notifications. And here, you actually have to read the messages to be able to distinguish these two things. So it's not habituation in the traditional sense that is happening here. So what is going on? So here's my best guess at what is happening. So this is basically a theory of planned behavior version of an account of how these suggestions work. Like you can use value expectancy theory of take your pick of your favorite behavioral theory. Most of these constructs are going to be the same. But basically, if we think about what an activity suggestions does, it's a prime, right? It increases the salience of PA goals, which then if in best case scenario should lead to an intention to follow the suggestion and then to some near-term activity. Of course, this increased salience might have some kind of a longer decay function, so it might actually result in behavior down the line. But insofar as we're only looking at that 30-minute window, that's kind of what is going on, right? So you need to form an intention relatively soon, and that might result in the near-term behavior. But this might actually be modified by a couple of things. So thinking about the standard theory planned behavior model, right? The main constructs here really have to do with attitude, right? And which is sort of the perceived value of that particular action, as well as the perceived behavioral control or self-efficacy for being able to do this in the moment. And in this particular case, you can sort of think about the perceived burden, right? I should say burden, not burden, but I apologize for that. Really, there's probably two sources of this. One is annoyance that really just comes from pinging people with push notifications. Well, the other one comes from the effort that is actually required in doing that action, right? Well, for perceived behavioral control, you can sort of think about this having to do with the current context. So if someone is in a meeting or in a webinar and ask them to walk, they currently can't do that, right? So the self-efficacy for being able to do that action in the near term is pretty low. Well, as well as if you can sort of think about these things like self-efficacy are pretty heavily autoregressive processes, right? So if I feel like if I ask someone to go for a walk multiple times and the context is pretty crappy most of the time, that self-efficacy, that low self-efficacy is just going to carry over into the future, right? And so you might just by virtue of previous responses or lack of responding to the suggestion, you might actually be less likely to respond in the future as well, because that sort of self-efficacy, you can actually do that with decay. What's interesting, I think, is that these two types of suggestions activate this process in somewhat different ways. So if we look at anti-sedentary suggestions, most of the burden is going to be coming from just the annoyance of being actually prompted by notifications, right? Because the actual required effort to do the action is pretty low, right? The value of the action itself might change over time, right? And for example, you can think about how long someone has been sitting when they receive the notification as being a key thing that determines the value of that notification. But given that we were not modeling that in this particular case, like that's not going to actually be affected either by the dose or the timing study, right? And so really, if we think about anti-sedentary suggestions, the key thing that the part of this process that is really influenced by notifications is that's part of the burden that has to do with annoyance. And really the frequency of notifications is the key thing that actually does that. Well, for walk-in suggestions, the things are a little bit different, right? The required effort to do that most of the burden is going to come from that required effort that's actually involved in going for a walk, right? That's substantially higher, and probably substantially higher than the annoyance from being notified through push notification in the first place. So that effort is going to carry most of the weight on the burden side. The value itself, on the other hand, might be something, especially given that you're actually asking people to do something that interrupts their current activity. They need to go out and spend a non-trivial amount of time walking and then coming back. It's possible that as the time sort of goes on over the course of the study, that perceived value decreases, right? And then so over time, that as they start doing these things, they realize it's really not adding that many steps to their day. It might not be worth the trouble, right? But we also have something going on the behavioral control side of things, right? So the context is clearly going to be a big determinant of whether someone feels like they're actually able to follow the intervention or not, right? And so that is going to be changing based on when they actually received it. But that notion of response to previous suggestions might actually also be influenced by time in study, right? So the longer someone is in the study, especially if as they start sort of getting these messages in context when they're not able to follow them, that might decay to what extent that response to previous suggestions is influencing the current default state of that self-efficacy, right? So in this particular case, it's really is the time of study that's operating, but it's not operating by itself, right? It's operating potentially through the changes in perceived value, as well as the changes in the sort of that accumulation of low self-efficacy that might come from the receiving these suggestions in context when they're not be able to actually interrupt their current activity and go for a walk. And so that's sort of another example of how the specific parts of the design, in this particular case, the content of the intervention, might make a difference in terms of what part of the causal process is actually activated. But the similar stuff happens for implementation strategies as well, right? And so here is one example, right? So here is an example of what we're calling micro theories that were so on one of the grants that Kara Lewis originally was a PI on, but Brian Weiner and Byron Powell and Mike Pullman and Aaron Lyon and I are on. We're trying to develop these sort of micro theories of common implementation strategies, and this is our current, based on the current literature, our sense of how clinical reminders might operate, right? And if you look at some of the key moderators that emerge from the literature, so the things like ability to easily interpret the reminder, alert fatigue, task interruption, right, perceived relevance, and task discordance. These all seem to match up pretty well to some of the sort of the design dimensions that have been identified in the literature as being really important for the effectiveness of clinical reminders. Like, so the number of reminders is a sort of a key thing that's going to address the alert fatigue. Like the alert design, as well as the design of the content, is going to affect whether a clinician is able to interpret the reminder and to do that quickly, right? As well as to what extent the reminders are integrated into the workflow is going to address this kind of thing like the task discordance and task interruption that we're identifying as barriers to use of clinical reminders. So the sort of properties of the reminders in this particular case very much again directly match up to some of the sort of visual aspects. I mean, some of the causal aspects of the process through which this strategy is theorized to operate. And so I just want to end on and this came to me a little while ago, and I just want to sort of end on it as a provocation, and I'll be curious to hear how you guys think. But in implementation science, but as well as in the interventional work, we often talk about fidelity, right? And the notion of that we want to provide interventions and implementation strategies with fidelity. And so one way of thinking about fidelity is that really it's fidelity really refers to that interventional strategy is delivered in a way that actuates the same aspects of the of the causal pathway at roughly similar levels as the interventions or strategy that was initially studied, right? So you can sort of allow for all kinds of adaptations, whether training is done via in-person or through online units, or even through by giving people little unit, micro training sessions through text messaging. As long as you can sort of account for all of the key aspects of the causal pathway that the original intervention or strategy that was originally tested were involved, right? So as long as all of the moderators that the original intervention or strategy addressed, all of the preconditions that needed to be in place, if the adaptation of that strategy or intervention can address all of those causal elements similarly enough, you can think of that as providing that interventional strategy with fidelity, even if the form of it is quite different than what was originally tested. All right, so I'm going to finish up so we have a few minutes for questions. So basically what I try to argue is that specifics of the design of an intervention or an implementation strategy can result in differential activation of this causal process through which that intervention or strategy operates. theorizing about those things, so making them explicit at the level of individual strategies or individual intervention components, allow us to both better understand how these strategies or interventions work, as well as to predict what design decisions are likely to matter, right? So if your design decision is not actually affecting any of the key moderators or preconditions in your causal path, in your best sort of thinking about how this thing is supposed to work, it might not actually matter, right? Well, if it does, that might be something that you need to be thinking about. And doing this on a consistent basis, I think, can eventually result in more robust evidence about how to effectively design interventions and implementation strategies. So I'll end there. A lot of this work, of course, doesn't happen in isolation. We have a lot of collaborators. These are just some of them. But I'll stop there and I'll take any questions you guys have. And I'll stop sharing so I can see you all.
That was amazing. Thank you. So we had one question about sharing the presentation later, which I was able to respond to. So folks, please feel free to jump in. But one of the things I was wondering, do you ever manipulate, and sorry if I missed it, but the idea of over the course of time, the fact that people are habituating, like, could you then change the randomization frequencies?
Yes.
Yeah, do you do that?
Also, right, and that's actually what we do once we start incorporating reinforcement learning algorithms. And so the last couple of deployments of hard steps very much manipulated the randomization probabilities at each decision point. So we basically take, for each person, we construct a person-specific model that gets updated in our case every day based on their response patterns. And we basically sort of to tweak the probabilities, so we provide these interventions in context in which people are most likely to respond, right? So so that is one way of dealing with this. I think that's the more and in terms of, if you're just interested in sort of deploying things that work, that level is probably fine. Like if you just have an algorithm that can pick up on the right signals and adjust probabilities to do more of the right things at times when someone is likely to respond versus at times when they're not likely to respond, the system will get better. I think for a lot of things, though, we can't quite sort of take that approach, especially if you're thinking about visual design, right? A lot of the in-app functionality we have to design visually in some way, right? Mm-hmm. And you have to make decisions like, do you have extra goals or not, right? And for that kind of stuff, I think sort of trying to at least articulate what that underlying process is through which this is going to work, and how those design decisions would map to it, I think becomes really important, right? Mm-hmm. And so if for push notifications, I think the timing ends up being such a key part, and or any kind of a push intervention, that I think model sort of individual level models that evolve over time can probably get us most of the way purely through data-driven approaches. But I think if we're going to really start accumulating evidence about like what operationalizations you need to use in what context, we need something that goes under the surface to try to understand what's the underlying causal process.
Just earlier today, David and I were starting to talk about notifications, and to your point, just that alone and how to design them, and like you're saying with the interface, it's really a lot.
We in HCI, in human computer interaction, we always say, design matters, right? It's sort of a mantra of the field, but it's really hand wavy around why it matters, right? So we think, well, usability is going to be higher, so people are going to be more engaged, but I never found that as a completely satisfying account, right? Yes, usability does matter, but I think with something like those planning prompts, I honestly don't know that, especially given with the younger population that is really pretty apt at writing on a phone, that usability of one interface versus the other was all that different. Like something else was going on, right? I mean, and so I think then trying to really understand what that is and what that means for the future, right? So in the current version of Hard Steps, we don't ask people to write a plan because it is still relatively burdensome, but we have a structured form that takes some time, right? So you basically you have to select an activity and you have to select the time, and the hope is that is sufficient to actually engage enough attention for that process to still unfold as it's supposed to.
I think the phrasing is spot on around engaging, and that's what we think about also here. And it's in the sense of engaging to then facilitate behavior change. So it's sort of like, obviously we're on the same page on that, but in the sense of like, what is really that design reinforcing and what are you not reinforcing as a result? And so, for example, in a similar intervention that we have that to promote healthy behaviors, we realized from a goal setting perspective, we weren't reinforcing, like our design forgot to do something. And so clinically people weren't doing what we wanted. And so it's a simple design UI change, so to speak, but like actually the behavior change processes are really different consequently.
Right.
Exactly. Yep.
Yeah. And then for something like those anti-sedentary walking suggestions, really it was just text, right? And so, and it's weird. Timing study is a weird construct. It really, really is. Like it's not something, other than just sort of novelty effect, right?
Yeah.
Or say, okay, so people get excited early on and then they stop being, but that's not a particularly satisfying psychological mechanism, right? For longer term studies. So trying to really figure out, okay, so, and it's not like habituation from the reflex literature is very much a response to just the prod, right? You shine light into someone's eye, or you smack their knee and the thing responds, right? And so in our case, the equivalent of that is really getting a notification. It's really the push. But if that's the case, then there should be no difference between the content, because it's really just the actual the prod itself is the thing that should be leading to habituation. But clearly, if I'm actually seeing a difference in the response pattern, that means that people are at least sufficiently engaging to read this thing, right? And so exactly. A slightly different process might be happening here.
Yeah. We have lots of great questions coming in. Selfishly, though, I just want to ask one quick one. And then if the answer is yes, would love to talk another time and get to other people's questions. Have you implemented MRT with implementation strategies yet?
MRT with implementation intentions?
Like how you were matching, no, but like doing it in the EHR level.
Oh, at the EHR level. I have not done an MRT in EHR yet. I would like to do that because I think we could get some pretty cool data, but I haven't been able to do that yet.
Yeah, exactly. Okay. Would love to chat more. But so let me ask other people's questions because I would love to get to those. So Ellie Burgess says, thank you for a great talk. In your opinion, what types of prompts or reminders are most uplifting for people to engage in physical activity? What messages and visuals seem to be least guilt-inducing and more on the positive changes?
Yeah. So some of the recent work that we've been doing has been really focusing on the affective processes related to physical activity. And one of the things that we find, and honestly, I'll actually show you a screenshot of this. I might be able to pull it up pretty quickly. But so what we've been doing, so this is a student of mine, Sue Choi, who's been doing this work. But basically, she's been creating these little messages where they pair activity suggestions with funny gifs of animals, right? So that and some of them are cute and the waddle and whatnot. And one of the things that we find is that we can actually influence people's affective valuations of physical activity. That basically you can think of this as a basic classical conditioning or evaluative conditioning in this particular case, where you pair just a happy stimulus that makes people smile, which is pictures of cute animals, with some of this content around physical activity. And over time, and we're seeing this, we ran one 9-week study and one 12-week study, their actual valuations, how they feel about physical activity improves. And I think for long-term change, I'm at this point convinced that that's sort of the direction we'll have to go. Try to figure out how, as long as this is just another task that people have to do, and which is how a lot of our interventions have been structured, at some point people stop. And so for long-term change, and I've been particularly interested in sort of thinking about physical activity as a preventive strategy for Alzheimer's, right? That's a 20-year or 25-year sort of behavioral maintenance problem. And so if you're going to really deal with that I think some of these more positively framed interventions that can over time both influence people's affective responses to activity as well as their over time identity related to that health behavior, I think is probably the most promising way to go that I've at least thought about so far.
Frankly, I don't mean to be so conversational. This is great chatting about all this, but in the truth that your point about Alzheimer's, I mean, I don't mean to be pejorative, but the role of habituation looks different in that population, right? Because actually they may not remember seeing it. And so the novelty piece is really different in terms, so it's interesting.
Yeah, I mean, especially if you're working with people who already have Alzheimer's or
Exactly.
dementia, right? I mean, I think we're trying to
Not
start
prevention, but
early,
yeah.
right? Yeah, for primary prevention, in which case, it's people my age, which I mean, hopefully I still remember at least a little bit, not
Yeah.
much, but tiny bit.
Another thank you for a great talk. I was surprised that open-ended goal setting was effective, but choosing from a list wasn't. But it does make sense that open-ended required attention. In addition to attention, do you think that open-ended goal setting is more personalized to the person in the moment?
So, if the list itself was our plans, then absolutely. But with the way that the actual list worked is that the list itself got filled in by the open-ended plans people have made in the past.
Oh, nice.
So as the study progressed, we initially had sort of some relatively common plans for the first couple of days, a few days of the study. But every time someone would be randomized to make a new plan, that plan would replace one of the seed plans. And so within a few days, and certainly for the last 5 weeks of the study, that the plans that people were choosing from were their own plans. And what we find is that even when we ask people to write a new plan, they often write the same plan, right? Because our days look pretty similar for the most part, right? And so they might phrase it just a little bit differently, but the plans themselves, within person, there was not a huge amount of variations in the plans. And so then when they got the list, they got the plans that were actually their own. And so I don't know that being personalized to them was as big of a factor as really just to what extent they sort of cognitively engage with that process of planning.
Bonnie says hello and great talk per usual. Have you thought about how similar your view of fidelity is to the experimental medicine's conceptualization? It's a tall order, and I look forward to discussing again.
Not yet. I just honestly, as I was writing this talk, that this notion of fidelity really started gelling for me only the last couple of days. So I'd love to talk to you about this, Bonnie, because I'm not even sure whether it has any legs. But it does seem to me that that's one way to think for how to think about what adaptations of an interventional strategy would result in something that you can, in some meaningful sense, is still call the same thing, right? Whether it's the same intervention or strategy, that and whether that corresponds cleanly to the notion of fidelity or not, I'm not sure. But I think it's one way of thinking about can we actually make an adaptation that is to a new setting or to a new context, but still sort of rely on the evidence that we had from the previous deployments. And so I would love to talk more about that. Like I'm not, again, I sort of threw it out as a provocation. I'm not ready to enter to that, but I'd love to chat more.
David, do you want to jump in on that though? Because to me, it seems very like form versus function. And in other ways, like you have to change certain things. You have to change, absolutely.
Absolutely.
Because, so it's interesting.
I think that's exactly right. The question is just what is the function, and I think in my thinking, really the way to think about the function, the more abstract version, is the causal process, right? Mm-hmm. And so I think you're exactly right. That's another.
But implementation scientists will start to argue it becomes different. Yeah.
Right. But every conversation I've had with people in implementation science about, well, when does it become different, gets super hand wavy, right? I mean, it's like, well, how do you decide which adaptations actually matter?
Mm-hmm. Yeah. Related to implementation science, someone asked that their Paige writes, I'm interested in your class. Is it graduate or undergraduate? What types of majors represent the students in the class? Computer science, data science, psychology. It seems important to develop new types of courses to advance digital mental health intervention development and implementation.
Oh, thanks for that question. It's a master's level class, and it's kind of a mix of students from the School of Information, most of whom are really sort of studying user-centered design and human-centered design, and then students from public health. So I typically get sort of, it used to be about half. Now it's about 2/3 of the students who are either in our Masters of Information or Masters of Health Informatics programs, who are basically going to be developing computing systems of some sort, and many of them who come to do my class, take my class, want to go into health area, and then students from more traditional sort of intervention disciplines like public health. So what's nice about that mix is that I get some students who are much stronger on the theory side, I get some students who are stronger on the design side, and so for a lot of their group projects, you end up with both of those sources of expertise, which is great.
It's like the training institute. It's great. It's cool.
Exactly.
It brings people together. Yeah. And so last question, I know we have just a few minutes. So thank you for this presentation. Everyone's really loving it. In your diagrams, have you gone about identifying the moderators and any tips for that? Is it identifying barriers ahead of time, or is it more theory driven? I'm wondering if we're capturing all the relevant ones.
Right. No, great question. So in this project that I mentioned briefly, where we're basically trying to come up with these micro theories of individual implementation strategies, we basically start with theoretical work insofar as it's there, and turns out for a lot of our strategies there's very little sort of theory, right? And then we look at the systematic reviews, and we look at the literature on that has assessed various kinds of moderators, and we try to compile moderators and preconditions from that. And then when we fail with all of the other methods, we basically sort of we'll try to come up with things that make sense, right? And so we very much think of this as a sort of offering hypotheses about how these strategies work that the field can throw mud at and improve, right? Rather than sort of these are definitive theories of how this works, right? But the thought is that even just making it explicit would allow us to have more informal conversations about how do these strategies work and improve that over time, right? In terms of the actual strategies that you might use in a concrete initiative, or if you're designing an intervention, a behavior change intervention, I mean, similar kind of reasoning goes, right? Insofar as we have the literature, we start with that. But I think even sort of putting hypotheses, even if they're sort of loose hypotheses about how might something work, we find is actually pretty helpful. The key part is to try to understand, what's your confidence about various pieces of this, right? And for things that we're pulling out of thin air, the confidence is going to be pretty low. For things for which we have, robust literature and systematic reviews, it's going to be better. But I think that I really think of them more as process representations, like that their value comes from just actually doing it, to clarify your thinking, rather than this is the sort of the final product that I'm going to put on the wall and say, here, I get a gold star for creating this thing. And so I think it's really more about sort of encouraging thinking, both at a level of a field. So we're writing some papers that are going to now sort of propose these micro theories of common strategies, just for people to respond to, but as well as in the sort of intervention development or strategy development process, really to sort of make concrete decisions, like, okay, do I need another strategy to address any of the moderators for this current strategy? Like, do I need to sequence things differently? So if you have a precondition for one strategy, you might need to actually a different strategy to happen first to address that precondition before you deploy the second strategy, right? So there's a lot, sort of very much we're thinking of them as practical tools to help you make decisions along the way when a strategy or intervention is being designed.
Thank you. We're at 1 o'clock. This was wonderful. We really appreciate, very thought-provoking. Join us next month. We'll have Adam Greasley. We're excited.
Awesome.
Thank you so much
for the invitation. This was a lot of fun.